So I think everyone is aware that there's a dramatic increase in autism diagnosis. And I think that if you listen to some, that is portrayed as an epidemic or something that's this profound difference that's happened in our society. Most of the evidence doesn't support that at all.
Autism. It seems to be a topic of conversation everywhere these days, with debates over the causes, the symptoms, and prognosis. There's no doubt more children are being diagnosed. According to a recent CDC report, about 1 in 31 children in the US has autism. That's up from 1 in 150 in the year 2000. But does that increase mean instances are actually going up? Or are we simply recognizing it more? Hi, I'm Derek Angus, a physician and senior editor at JAMA. You're listening to Healthy Dialogue, a new podcast from the JAMA network, where we'll be discussing some of the most pressing issues in health and healthcare with leading experts from around the world. Today, I'm joined by JAMA Psychiatry Editor-in-Chief Dost Öngür and Jeremy Veenstra-VanderWeele, Professor of Developmental Neuropsychiatry at Columbia University, to get some clarity. What is autism? What do we know about the causes? What treatments are available? And can we make some sense of the whirlwind of information in the news? Welcome, Jeremy and Dost.
Thank you, Jeremy, for joining us and for taking the time. It's really great to have you talking with us. So, Derek, as you know, Jeremy's a professor of psychiatry at Columbia University Medical Center and a child psychiatrist, and really just a foremost expert on most things child psychiatry, including on autism. It's great to have you with us.
It's great to be with you. That's a generous introduction.
So, Jeremy, could you just go over what the official term autism actually means?
One of the interesting things about the diagnosis of autism is that until just a couple of years ago, the first person diagnosed with autism was still living. And that's a remarkable thing, right? It isn't something that we usually think about. But in 1943, Leo Kanner here in the US published the first description of people with what he described as a disorder of affective contact, autism, which is derived from a term that means alone. And that was what stood out to him in the initial description. A group of kids who seemed disconnected from others, other adults, but also certainly other kids. I think that is what people usually think about, that social disconnection, which isn't just lack of interest. It's oftentimes somebody who might be quite interested in others, but struggles to navigate an interaction. The other component that he described, we today broadly describe as repetitive behavior. But what he articulated was this, which is just such an elegant phrase, insistence on sameness, this sense of wanting things to happen just the same way in order to feel comfortable or that things were right. And I think we have since then come to understand autism as much broader than the initial set of kids that he described. But these remain the core elements. Difficulties with social communication, which we separated for a time in psychiatry, social difficulties and communication difficulties, but it turns out you can't be social without communicating and vice versa. So those are now lumped together in our criteria. And then repetitive behavior, which we understand to include insistence on sameness, but other things from being super interested in trains to all sorts of other things.
And you said that the first discussion in the medical literature was from the 1940s. But presumably people had this before. It didn't begin in the 1940s.
That's what we imagine. Of course, not being able to go back in time, it's hard to be entirely certain.
And why do you think, Jeremy, that it took until the 1940s for a clinician to formulate this and describe it if it was there in history?
Part of the emergence likely corresponds to people finally starting to pay attention to the inner lives of children, which prior, certainly to the 20th century, was not an area of much focus. Certainly, Freud thought about people's description of their own childhood as quite important, but Freud by and large, wasn't talking to children. He was talking to adults about their experience as children. It actually wasn't until the 20th century where you would have somebody who had described themselves as a child and adolescent psychiatrist. And in fact, Leo Kanner, who described the features of autism, is usually given the title father of child psychiatry, at least in the US. So I think that's a piece of it. I suspect that there are other pieces that go along with that, including sort of a shift over time in the importance placed on people's inner lives and a shift from a more community focus. People are expected to do certain things in their roles in a family structure or community versus a more individual focus. But many of our diagnoses in psychiatry didn't become clear until the 20th century in any case.
This must be in a spectrum. There have to be some people with paralyzing fixation on sameness versus others who only express it a little bit. And then there also have to be people that have terrible social communication skills versus people that are only somewhat shuttering in their social interactions. Is that where the term ASD comes from, or where the grades of severity within autism arise?
Like in many areas of medicine, we've drawn lines at different places over time. And you could look at blood pressure as an example of this. Well, what's a problematic blood pressure from the perspective of a primary care doctor or a cardiologist has changed over the last 100 years. And we have substantially loosened our criteria for autism over time. Not that we're failing to be specific, but that we're less rigid about how we're applying things. And that's happened over the last 40 years, really. And that evolved from initial description of autism by Leo Kanner to acknowledging kids who were close but not quite in that autism bucket. And so that led to a diagnosis called pervasive developmental disorder or pervasive developmental disorder not otherwise specified. It's a mouthful. It also doesn't give you much specificity in that not specified category. And then in the 1990s, we added a diagnosis that was described as Asperger's syndrome or Asperger's disorder. And that was based on a parallel description of people who had difficulties with social communication and repetitive behavior, but did not have cognitive impairment and did not have obvious language impairment. So Asperger described kids who probably Leo Kanner could have described just as easily, but he highlighted those kids who didn't have other areas of impairment. And so that became the description of Asperger's syndrome or Asperger's syndrome. And then over time, there came to be this recognition that we weren't systematically applying these diagnoses. So one person might go and see an expert in Chicago and get a diagnosis of autism, and might go to Wisconsin and get a diagnosis of pervasive developmental disorder not otherwise specified, and might see somebody in New York who said, well, you have Asperger's syndrome. And a number of folks pointed out this problem, and ultimately Kathy Lord and colleagues articulated the problem very clearly and then brought data forward to demonstrate that there were no natural divisions between these diagnoses. And as a result, you kind of got the favorite diagnosis of whoever you saw within limits. And so then in 2013, the new edition of our diagnostic manual just said autism spectrum disorder, lumped all of these things together. And as that happened, it also added a couple of additional wrinkles. One is you could either have these difficulties now or by history. So allowing any difficulties over the course of your life to sort of come into this diagnostic moment. And then also added some flexibility around developmental characteristics so that the social communication difficulties would apply to somebody who has a developmental age of 6 months or 60 years. So it could be somebody who had very fluent speech, but still struggled to modulate social interactions.
So can I just jump in? I think this brings us to this notion of changing prevalence of autism in society. Because as you just described, over its history, the definition of autism and related disorders has been evolving. And if you, of course, change the definition, you'll capture different groups of people if you're counting the people who meet that definition. So can you tell us a little bit about that, the changing prevalence of autism in society?
Yeah, so I think everyone is aware that there is a dramatic increase in autism diagnosis. And I think that if you listen to some, that is portrayed as an epidemic or something that's this profound difference that's happened in our society. Most of the evidence doesn't support that at all. What I just walked through is very clear, right? We dramatically change where we draw our line. And all of a sudden, there are many more people who fit within this spectrum diagnosis. That should come as a surprise to absolutely no one, right? If you changed what is considered high blood pressure, no one would be shocked that the rate of high blood pressure would change. But because this is diagnosed not by a number, but by features that are seen by a clinician in an office, it feels more mysterious. And it feels like more people being labeled as autistic means that there's some profound change in society. That's the biggest thing. There's all sorts of things that certainly contribute. We now know how to diagnose autism more clearly. We have tools to do that. We didn't used to. We now use defined interviews, semi-structured interviews, play assessments, all sorts of new tools that we didn't have 30 or 40 years ago. We're also more conscious of this. It used to be when I first saw somebody receive a diagnosis of autism, the family was devastated. They were shocked. They didn't know much about autism. What they had read about suggested that this revealed some fault in the family. They thought that this was a life sentence, somebody who would be dependent for the rest of their lives. Of course, that doesn't describe the diagnosis today. Most parents that I see now are not surprised when their child gets a diagnosis. They had already suspected this. They've watched videos of kids online. They understand the spectrum. They're not devastated in that same way. We shouldn't be surprised the numbers have changed when all of these things have changed in parallel.
Discussing how autism diagnosis has changed over time got me thinking about a trend that I've been hearing about, even from sort of colleagues of mine, in particular female colleagues. And that trend is people being diagnosed with autism as adults. Indeed, there's a recent study in JAMA Network Open that found that between 2011 and 2022, autism diagnosis in young people, people aged 26 to 34, had increased 450%. Now, that same study found that while males are more likely to be diagnosed, the gap between men and women was narrowing. And so I asked Jeremy, what might be contributing to these trends?
Sexism is real, and people perceive others on the basis in part around stereotypes based on gender and other things. And that certainly has been the case in autism diagnosis, that we have developed our criteria and our training videos and everything else around the idea and the reality of boys with an autism diagnosis, and we're not as good at detecting it and seeing it in girls. At the same time, it does seem quite clear that autism is more common in males. Interestingly, that severe autism, profound autism, autism with intellectual disability, may actually even that out some, meaning that if somebody has autism and intellectual disability and epilepsy, they're a little bit more likely to be male, but it's pretty even between male and female. Whereas if somebody has quite mild autistic traits, they're much more likely to be male. So it's, I think, both things: failure to recognize, failure to apply the criteria faithfully, and criteria that are certainly sex biased. We do see a lot of autism diagnoses now in adults. I will say it's sort of interesting. If you think that you're in the midst of an epidemic, that shouldn't be the case, right? It should be that this is only happening in young kids. And every adult who's diagnosed with autism is an argument against the idea of an epidemic.
This brings up the question of what do we know about the brain mechanisms of autism and causes of autism?
So the data, and going back really to the late 1970s, the data have been very clear that genetics is the primary identifiable risk factor that predicts autism diagnosis. And that's from twin studies, it's from family studies, but most recently it's from studies that actually identify genes that are clearly implicated in autism. None of those genes are strictly causal, which is to say, I can't say, well, you have this genetic change and so you have autism. But what you can say is the reverse, that if you didn't have that genetic change, you wouldn't have autism, if that makes sense. And those genes are found in roughly 15 or so percent of individuals with an autism diagnosis. And they're much more commonly found in folks who are described as this category of profound autism, autism with intellectual disability, autism with epilepsy. You do find some of those rare genes in individuals who don't carry an intellectual disability or epilepsy diagnosis, but most of it's in that group. And that's 15%. Some of the other 85% is probably genes that we just have to find yet. So, and then other stuff. Being born extremely preterm with very low birth weight clearly increases your likelihood of having an autism diagnosis, as well as intellectual disability, cerebral palsy, a number of other things. Very clear. Being born with a short gap between you and your next older sibling clearly increases likelihood of having an autism diagnosis. Interesting, makes you think about a deficit model where there's something that's depleted in a pregnancy, and then there needs to be some recovery. It may be simpler than that. It may be that just increases the likelihood of pregnancy complications, having two kids very close to one another. Lots of pregnancy complications lumped together seem to increase likelihood, each one by a pretty small amount if you looked at it individually. Infections during pregnancy, particularly severe infections during pregnancy. So there's a common theme here. It sounds like things that are bad for a developing fetus, that are bad during pregnancy, increase likelihood. And then advanced parental age, which may be in part due to increased likelihood of mutations, particularly inherited from dads, mutations that are happening in sperm. You'll note I have not mentioned vaccines or acetaminophen. The evidence is reasonably clear that acetaminophen does not increase likelihood of autism once you appropriately control for things. You have to ask appropriately if people who are exposed to acetaminophen might be taking it because they have a fever. And fever is a sign of infection, and infection increases autism risk. So let's control for that. And then if there are relationships between genetics and likelihood of taking acetaminophen, say for headaches, which appear to be a little bit more common in relatives of people with autism. When you appropriately control, any effect of acetaminophen goes away. And vaccines, this one is just heartbreaking because one of the clearest ways to prevent autism is to avoid German measles, rubella during pregnancy. So when you go in for a prenatal visit, they check to see if you have antibodies to rubella. It's one of the clearest things we can do to prevent autism, and kids who are exposed to rubella during pregnancy usually also have intellectual disability. We need to stop studying this and move on to something else.
Could we just talk for a moment about what the consequences are of having autism? If I understand correctly, there's maybe two ways of thinking about it. One is how severe the autism itself is, how severe the impairment to social communication or the degree of fixation on sameness and repetitiveness. But then the other issue seems to be autism coexists with other problems. There can be people with intellectual disabilities, with epilepsy, with other neurodevelopmental impairment. So I could imagine that if you get a diagnosis of autism, there are two things to worry about. One, how bad is the autism? And two, what else might you also have that comes in parallel with the autism?
That second piece is where more of the evidence is, which is to say that those things that are diagnosed or diagnosable alongside autism predict outcomes to a larger extent, actually, than what could be described as the severity of somebody's autistic traits. And I think now is as good a time as any to acknowledge the other thing that's happened as the spectrum has broadened, is that there are now multiple ways of formulating what autism is. So broadly speaking, you could think of that as medical model, right? I tick off features or traits or symptoms, and somebody gets a diagnosis or not. The other model can be described in multiple ways. Some people describe it as the neurodiversity model. I think of it more as the identity model. So somebody sees traits in themselves, acknowledges that those traits, broadly speaking, fit into this characteristic that's been described as autistic, and say, I'm an autistic person, and that's why I struggle with this or that, or that's why I can focus on this thing to the exclusion of all else and may be really excellent in my sphere. And those models don't always get along. But what is interesting is that the predictor of outcomes actually turns out not to be the severity of, in the identity model, autistic traits, and in the medical model, autism symptoms, but instead tends to be predicted by an individual's ability to speak, an individual's IQ. These spheres where back in the day we would say comorbidity. Now we typically say co-occurring problem or diagnosis. But intellectual disability is the big one. Somebody who has a diagnosis of autism and intellectual disability typically will be dependent on the care of others to some degree over the course of their lifetime. And somebody who doesn't have intellectual disability oftentimes is not.
So intellectual disability is not actually part and parcel of the diagnosis of autism, despite the fact that much of the stigma in society might be that someone with autism might have intellectual disability. And there's an increased likelihood that people with autism will also, unfortunately, have intellectual disability. But it's not the autism itself. It's like a co-located problem.
Yes, and some people now describe it, and it's not, I wouldn't describe it as a diagnosis, but describe a group of people who have profound autism. That's the term that's been used some. And what that really means is a diagnosis of autism plus a diagnosis of intellectual disability, and usually enough communication disability that they're unable to communicate their basic wants and needs. And coming along with that, just as any of us experience if we travel to a country where we do not speak the language and cannot communicate with anyone, a much higher rate of irritability and coming with that sometimes self-injury or aggression. This group of people is a group that we need to figure out how to serve better because we've lumped everyone together, right? We really struggle to say we're going to try to develop better care for those individuals when there's another group of individuals who can speak for themselves, could be on this podcast, maybe more eloquent than me, and feel like the priority on those folks who can't speak for themselves may be misplaced, or that there may be things that we're trying to do to help that population that another group of individuals who share a diagnosis feel, that really isn't what you should be doing. That isn't what I want somebody to do for me. And this lumping has resulted in a substantial challenge as we try to come up with better ways to provide care, to provide education, and to help people across the course of their lifespan.
So, at this point, we've covered changes in diagnosis, some very interesting history, some risk factors, and the wide range of what having autism spectrum disorder actually means. But what about getting to that diagnosis? And once you do, what treatments and support are available? In the final segment of today's episode, I wanted to learn more about the reality for patients and their families, starting with the very first step of how you actually get to the clinic and first encounter the healthcare system.
Families sometimes describe this as a diagnostic odyssey, which can be quite frustrating, but it doesn't necessarily have to be. There are screening tools that pediatricians use, and the pediatricians in your audience will already be thinking about them, that can be very helpful in identifying whether there may be a developmental problem, but usually are not very specific in saying what the problem is. And so if you apply one of those tools, and there are several of them, but if you apply one of those tools, or a parent comes in and says, I'm really concerned because Susie isn't talking at 2 years of age. That is a significant developmental concern, no question about it. There are essentially parallel paths that need to be initiated at that moment. One is obviously to get the child to somebody who is a developmental expert. That may be a developmental pediatrician, it may be a psychologist, it may be a neuropsychologist, sometimes is a neurologist, a psychiatrist, et cetera, but to somebody who's expert in doing these evaluations. The second is actually to already initiate the early intervention evaluation process, which is different in every state, but you want to start in parallel because some of those early interventions are not specific to an autism diagnosis. Speech therapy is going to be helpful whether a child has a diagnosis of autism or intellectual disability or has a speech articulation problem that is not going to be a long-term difficulty. So you want to initiate these things in parallel because you can already start to get services while you're unfortunately usually on a waiting list to see somebody who's expert in this space. We need more providers who are expert, and we have had an increase over time, but we need more still.
Okay, that sounds a bit complicated. I feel like in modern healthcare, People already complain about the sense that they almost have to be their own concierge. It's complicated negotiating online websites for places like Columbia University, New York Presbyterian, or UPMC, where I work, our own institutions. We know and have friends and family members who are trying to get in and see an orthopedic surgeon or a cardiologist, and it's hard enough to do that. It seems like quite a big ask for parents of a young child to negotiate all that you've just described. Do you think there are places where the system is well enough organized that the parent's job is just to get to the pediatrician, and once they get there, everything's just automatically activated? Or do you think that even after getting the diagnosis, a lot ends up still falling back on the shoulders of the parents, and that they have to become these kind of super advocates for their child?
I wish I could tell you that in this country there's a place where you just walk into the pediatrician's office, they identify a problem, and then a team is assembled and takes it from there. I don't know of a place in this country where that's how it works. Autism Speaks, which is worldwide but started in the US, has a kit they call the 100 Days Kit, and that's to help parents navigate this. And you really feel like, I shouldn't need a kit.
No,
I should just receive help, right? That's
I know.
That's what we're all looking for.
Doesn't my insurance provide the kit?
Right. There are countries that I think do this much more effectively than the US does. And there are healthcare systems where if you see a Columbia pediatrician and then want to see somebody who's an autism expert within the same system, there's a streamlined referral and linkage system. There are also people who are doing research to figure out how we do this more effectively. And one of the tools, one of the sort of magical providers that we talk about in the space is the family navigator or patient navigator, who actually does engage with that family and help them identify, okay, we need to get this appointment set, we need to get that appointment set, we need to go ahead and start the early intervention now, we need to rule out this thing or that thing. That does clearly help families, and there are systems where those linkages happen, but many insurance panels will not pay for that service. And so paradoxically, that tends to be more available to people who do not have private insurance, who have public insurance or Medicaid and are able to access some of those services. And again, only in some states, not in others.
Can you tell us a little bit about the current landscape of what is available as treatment for people diagnosed with this condition?
What most people at this point, I hope, know is that early intervention is important. So getting an early diagnosis and getting into what is described in different ways, but essentially behaviorally based intervention. You can think about this as intensive, usually one-on-one teaching to gain communication abilities, to address adaptive behavior, to be more comfortable interacting with others. And that can start as soon as somebody has a diagnosis, and most of the evidence suggesting it makes a difference extends to about first grade or so. That's where most of the data are, and it can make a huge difference. You can measure that in different ways, but in many studies, it seems to increase IQ by 15, sometimes even more points over the course of the intervention. So you're saying, well, if it's autism, why are we talking about it increasing IQ? So in study after study, it seems to improve people's ability to communicate, to interact in settings like getting an IQ test or in school. Doesn't necessarily move those core traits that we use to make a diagnosis, but sometimes can allow people to become more flexible and have a sort of more adaptive interaction with the world. So that's the big thing, right? Early and intensive behavioral intervention. It can be done in different ways. The old school way was, I would say, something that was experienced by a lot of kids as unpleasant. Sitting in a chair, somebody sitting right in front of them, demanding that they do the next thing before they get some sort of reward, sometimes a very crude reward like a treat, and sometimes just praise. We've moved beyond that to where most of this sort of intervention happens in the course of play. An adult playing with a child, over time, the child becoming a more active participant, leading the play, and the adult trying to stretch their communication ability, their adaptive behavior just a little bit further with each session.
And philosophically, in these behavioral therapies, has there been a movement away from trying to make a neurodiverse child neurotypical? And rather than keep the diagnosis, we can celebrate the neurodiversity, but we can help acquire skills so that you can function more effectively in the broader society without necessarily giving up any of the attributes, the positive attributes that go with your diagnosis?
So I would say yes, and
Okay.
so the yes is, I think in the very early days there was clearly a push to have kids mask their areas of difficulty, right? And instead of focusing on the kids' ability to interact with the world, to focus on the kids' ability to blend and look like they didn't have a diagnosis of autism. I would say in most contexts we've shifted away from that decades ago, that we're trying instead to help kids interact with the world on their terms, not to make it so that they are interested in airplanes and not trains, but to figure out how they can interact with the world in a way that they want to. That's the shift that certainly has happened over time. That's part of the shift to play. Now it's a kid playing with a therapist, and they're saying that sound in order to get the next toy that they're super excited about. Right? And they're doing it because they want to, not because they're forced to. So that shift is definitely real. And we don't really make as much impact with these therapies as you might imagine. So yes, we can make a 15-point IQ improvement, but most of the data suggests that we're not regularly taking a child who's autistic and making them quote unquote neurotypical. We are making it possible for them to interact with the world as an autistic person.
Okay, so Jeremy, where do you sit in the midst of all of this in terms of your optimism meter? Do you feel like we're in a much better place than we were? Are there big things that you're still hoping for?
Yeah, that's an interesting question. I don't oftentimes ask myself if I'm optimistic. I would say I'm hopeful in a few key areas. And I also think that we actually have seen substantial advances in other areas. So early intervention and the accessibility of autism diagnoses, where the average age used to be 5 or so, and it's come down in most states at least to where kids we think are getting robust early intervention more of the time, and we know that that can improve outcomes. I think there's reason to be optimistic. We also see more people who identify as autistic who are able to speak for themselves. And there's a real autistic voice in the world. That did not used to be the case. That's wonderful. And I think that that's an accomplishment, and also I think a reason for optimism. I do think for people who are impacted by profound autism as it's defined, and I will say I'm a little uncomfortable with that term, but autism plus intellectual disability and often other co-occurring neurological concerns, we need to do better, and we're not that far from potential breakthroughs where we can identify a gene much of the time. And if we could actually do something that would target that gene, it could lead to dramatic improvements. Probably not the sort of thing that would remove a diagnosis, and that's not our goal, but the sort of thing that might allow somebody to communicate more effectively, to be less frustrated in the world, to be better able to engage in a vocation that they experience as meaningful, to be better able to communicate to the people that they love in a way that I think would substantially improve well-being. So I do think that there are opportunities there, and I think that there are also opportunities to help people who are less significantly impacted deal with some of the consequences of being autistic in a non-autistic world. So effectively treating ADHD we've talked about, but preventing depression, preventing this sort of emotional consequences of not being able to navigate relationships that matter to you, but can be really complicated. So depression is more common in somebody with a diagnosis of autism. Suicide is more common in somebody with a diagnosis of autism. We can do things about that if we actually take the time to study them and to formulate approaches that might be helpful and to involve autistic people in that process.
Well, that sounds like a great note to end on, Jeremy. I just want to say again, I learned a lot in our conversation today.
So did I. I have to admit, as a psychiatrist, I thought I knew something about autism, but it's been really great hearing about everything you talked about, Jeremy.
Yeah, Dost, you sounded smart about autism until I met Jeremy. But
Could always find one better.
Well, thank you. Very, very generous and fun to have this conversation.
Thanks for tuning in to this episode of Healthy Dialogue, where we've been discussing autism with Dr. Jeremy Veenstra-VanderWeele and Dr. Dost Öngür. We hope you found the discussion informative and thought-provoking. To learn more about JAMA Network research on autism, check out the resources linked in our episode notes. If you'd like to continue today's conversation, please subscribe, rate, and share this podcast. You can also email us questions related to this podcast at healthydialogue@jamanetwork.org. Your feedback helps us grow and continue to bring you insights from experts in the field. Until next time, thank you for listening. This episode was produced by me, Derek Angus, Dost Öngür, Matthew O'Connor, and Shelley Steffens. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.